iPhone disconnected. Please charge now. iPhone connected to iPhone.
Hi, very good evening. So today's live session we shall focus on a few multiple choice questions from Oral Path and Medicine Part 2. So I've shared the soft copy of MCQs in our Google group. I hope you have gone through them. I even shared tomorrow's MCQs as well from my group, right? So we shall have discussion in those 5 multiple choice questions, and I even put the title based on the topics which we are going to discuss today, right? So I hope you have gone through the soft copy and you have answered the questions. We shall have discussion pertaining to those multiple choice questions today, right? And a very good evening all of you once again. Hi Srish, hi Ganga, hi Harjit, hi Subhasish, hello. Hi Purvil, hi Parichay, good evening. Hi Rupali, hi Ajaj, Sita, B.A. Akshaya Subramaniam, hi. Hi Sanjay, hi Gargi, a very good evening. So we shall start with our first question. Unicameral bone cyst, U-N-I-C-A-M-E-R-A-L, unicameral bone cyst is option A, true cyst, option B, false cyst or pseudocyst, option C, both, option D, none. So unicameral bone cyst is what kind of cyst? So first of all, what do you mean by the term unicameral? Hi Kushbu. Hi Anupriya, good evening. Yes, Srish, Akshaya, Anu, Purvil, hi Chovana. So you mean to say it is pseudocyst? Okay. What do you mean by the term unicameral? Exactly, very good Akshaya. So unicameral is something which has a single chamber. So that's the literal meaning of the term unicameral. Unicameral means single chamber. Yes, so unicameral bone cyst is nothing but traumatic cyst, solitary bone cyst, or simple bone cyst, extravasation cyst, hemorrhagic cyst, or idiopathic bone cyst. So all these are synonyms of unicameral cyst or traumatic cyst. We have discussed in detail pertaining to traumatic cyst in our E-classes. We had a textbook discussion on the following topic. You can refer that for more information. So this unicameral or traumatic cyst is considered to be a pseudo or false cyst as an epithelial lining is missing. So there is no epithelial lining surrounding the cavity. So as such, this is categorized as a pseudocyst. And this traumatic cyst is very much uncommon, that it is seen in only 1%, or it accounts for only 1% of all the jaw cysts, right? So unicameral bone cyst is option B, pseudocyst is more appropriate, right? Hi Aishwarya, a very good evening. Now let's move on to the next question. So the synonyms are very important, right? So try to get familiarized with the synonyms so that you will not have any confusion when a question is asked by picking up one of the words from the synonyms, right? So solitary bone cyst or traumatic bone cyst, idiopathic, we have n number of names for it. So unicameral bone cyst. Now coming to second question. Extreme fragility and porosity of bones is characteristically seen in. Extreme fragility and porosity of bones is characteristically seen in option A, Lobstein's disease, option B, osteogenesis imperfecta, option C, osteopetrosis, option D, both A and B. Good. So extreme fragility and porosity are characteristic features, primary clinical characteristic features of which of the following conditions? Lobstein's, osteogenesis imperfecta, osteopetrosis, both A and B. Hi Sunita, good evening. Yes, the right answer is osteogenesis imperfecta or brittle bone disease. So osteogenesis imperfecta is also called as Lobstein's disease, right? So both options A as well as B, that is option D is right answer. Lobstein's disease or osteogenesis imperfecta, right? Let me just ask you another question related to this. What are various other characteristic clinical features which are evident in case of osteogenesis imperfecta apart from brittleness or proneness to fracture? What else are considered to be characteristic, secondary characteristic clinical features of osteogenesis imperfecta? Yeah, hi Harjit, good evening. Hi Devna, very good evening. Yes, Shabi, bingo. Yes, Akshaya. Yes, blue sclera. So why do you find blue sclera in case of osteogenesis imperfecta? What makes the sclera appear to be bluish in color? Very good. Yes, Nikita. Yes, Harjit. We find blue sclera. So we have this porosity of bone, fragility of bones, more tendency to fracture, even though new bone is formed that is of imperfect quality, right? And apart from this, we have blue sclera. So why do you find this blue sclera? Yes, Ganga. So blue sclera is because of extreme thinning of the sclera. As a result, the underlying choroid plexus is clearly visible through the sclera. Choroid plexus is something, network of capillaries or blood vessels which is formed between retina on the deepest part and the sclera on the outermost layer. So between these two layers, retina and sclera, you have choroid plexus. Sclera is thinned out, as a result the choroid plexus is visible through the translucent sclera which has this bluish sclera, right? So that's very important. So name few conditions, another related question to the same. Name few conditions or syndromes where you find blue sclera. It's found in osteogenesis imperfecta, and along with that we have various other syndromes which exhibit blue sclera. Can you name them? Yes, thin cornea. Yes, BA. Hi Sashank, very good evening. Yes, very good. Rashmika, Chavi, Aishwarya. Yes. So conditions where you find blue sclera include osteopetrosis, fetal rickets, Turner's syndrome, Paget's disease, Marfan syndrome, Ehlers-Danlos syndrome, hyperelasticity, rubber man, and also in cases of normal infants, blue sclera is considered to be normal finding, right? So make a note of all these conditions. So blue sclera found in case of osteogenesis imperfecta or brittle bone disease or Lobstein's disease, and also is found in Ehlers-Danlos syndrome, Paget's disease, osteopetrosis, fetal rickets, Turner's syndrome, and even in normal infants, right? So you can just make a note of these points. Good. Impressive. So option D is right answer. Now moving on to third question. Achondroplasia, I think there is spelling mistake, it's not places, it's plasia. Achondroplasia is caused by mutation in gene. We had this question in NEET 2018. So I put forth the same question so that we can have elaborate explanation pertaining to genes coding and defective genes leading to various other syndromes, right? So achondroplasia is caused by mutation in gene. Option A, FGFR1, FGFR2, 3 and 4. So which one do you think is right answer? So achondroplasia has something to do with defective endochondral ossification or defective cartilage formation, isn't it? Yes. Aishwarya, Akshay, Harshit, Ganga, Gargi, Kushwaha. Yes, Anushka, Sunita, Suresh, Shavi. So you're almost all, I think most of you are following the latest paper also, which is very good. Good. Fibroblast growth factor 3, FGFR. So gene coding for this protein or receptor, if it is defective, it can lead to achondroplasia, right? Along with that, make a note of the following. Achondroplasia, as you know, as mentioned, is caused because of mutation in gene for fibroblast growth factor receptor 3, FGFR3. Option C is right answer. The gene has been mapped to band 4p16.3, a chromosome 4p16.3, and this defect leads to decreased endochondral ossification, inhibited proliferation of chondrocytes in growth plate cartilage, decreased cellular hypertrophy, and decreased cartilage matrix production, right? These are some of the manifestations because of defective gene which is responsible for coding FGFR3 receptor. And we have other options, FGFR1 and FGFR2, which are implicated in other syndromes. For example, take FGFR1. FGFR1 defect in gene coding for FGFR1 can lead to craniosynostosis syndrome. Defect in gene coding for FGFR2 can also lead to craniosynostosis syndrome. And defect in gene coding for FGFR3 can lead to achondroplasia, hypochondroplasia, as well as craniosynostosis syndrome. We have these tables given in Schaeffer, so you can go through them for more information. So genes coding for FGFR1, defect in those genes can lead to craniosynostosis syndrome, both FGFR1 and 2. Genes coding for FGFR3, defect in them can lead to achondroplasia, hypochondroplasia, as well as craniosynostosis syndrome, right? You can just make a list of this pertaining to other options, right? So nothing has been discussed regarding FGFR4, okay? So option C is right answer. Yes, Ganga. Now, coming to penultimate question. Fessas bodies are seen in. Fessas bodies, F-E-S-S-A-S. Fessas or Fessas? Fessas bodies are seen in. Option A, Colles anemia. Option B, aplastic anemia. Option C, polycythemia. Option D, iron deficiency anemia. So all the following syndromes, anemias, where do you find Fessas bodies? Yes, alpha thalassemia or beta thalassemia? In which thalassemia do you find this? Okay, Devna, if it is streaming late, you can just refresh your page or reopen your app. Very good, impressive. Fessas bodies are nothing but excess alpha chains which are precipitated within erythrocytes as well as their precursor cells. So these are nothing but Fessas bodies. See, in case of thalassemia, alpha or beta, it simply means that if I say alpha thalassemia, it means there is defect in alpha chain synthesis. If I say beta thalassemia, there is defective beta chain synthesis. So in case of beta thalassemias, because of defective beta chain synthesis, there is abnormal production of alpha chains, wherein there is accumulation of these excess alpha chains within erythrocytes as well as their precursor cells, and these are precipitated and they form inclusion bodies called Fessas bodies. So these are found in case of beta thalassemia, Cooley's anemia, Mediterranean anemia, or erythroblastic anemia. Because of accumulation of these Fessas bodies, there can be, the cells, erythrocytes as well as their precursors are more vulnerable for destruction, right? So this is a relevant point pertaining to that. So thalassemia, you find this Fessas bodies, right? So because of these Fessas bodies, there can be erythrocyte hemolysis and severe ineffective hematopoiesis. Very, very important, right? Yes. Hi Preeti. Hi Trophy. Okay, we shall continue with our final question. Antibodies implicated in pathogenesis of bullous pemphigoid include IgA, IgG, IgM and IgD. So which antibodies are implicated in pathogenesis of bullous pemphigoid? Okay, say hi. There you are. Say hi, Toffee. Hello. Hi, everyone. So Toffee is busy playing. Let's not disturb her. Hi, Deepthi. So antibodies implicated in pathogenesis of bullous pemphigoid include bullous pemphigoid BP. Yes, Shavi, even we do love her. Definitely, I'll convey all your love to Toffee. Yes. If you see, a bullous pemphigoid, first of all, is nothing but autoimmune, ABC, autoimmune, blistering, chronic disease with subepidermal bulla, right? So bullous pemphigoid is autoimmune, blistering, chronic disease with subepidermal blistering, rarely involving mucous membrane. This is very important. It rarely involves mucous membrane. So it is characterized by presence of immunoglobulin G, IgG, which are autoantibodies or which act against hemidesmosomes of bullous pemphigoid origin. So we have hemidesmosomes, bullous pemphigoid, BP230 and BP80. So these antibodies, IgG, are directed against hemidesmosome antigens or proteins, thereby leading to destruction of these hemidesmosomes, because of which there will be subepidermal bulla formation, right? IgG antibodies are implicated, autoantibodies, these are implicated in pathogenesis of bullous pemphigoid. So bullous pemphigoid is a chronic autoimmune subepidermal blistering skin disease that rarely involves mucous membrane, which is characterized by presence of immunoglobulin G. So we have these IgG antibodies which are specific for hemidesmosomal bullous pemphigoid antigens. Hemidesmosomal bullous pemphigoid antigens BP230 and BP180, right? So these antibodies bind to skin basement membrane. So hemidesmosomes are found in basement membrane. So these antibodies bind to this basement membrane and they activate complement system, which further leads to release of inflammatory mediators. And as a result of which there will be recruitment of various inflammatory cells and they release proteases, which leads to degradation of hemidesmosomal antigens or proteins, leading to formation of blister below the epidermis, subepidermal blister formation, characteristically seen in case of bullous pemphigoid. And also along with this, eosinophils are also abundantly found in histopathologic sections, right? So that's about bullous pemphigoid, which is an autoimmune blistering chronic subepidermal skin disease, right? So we have these IgG antibodies which are directed against hemidesmosomal bullous pemphigoid antigen number 230 and 180. As a result, the antibodies bind to these hemidesmosomes, leading to their destruction, which are, these hemidesmosomes are basically found in your junction, right? So basement membrane, so leading to formation of subepidermal bulla, right? So regarding the terms vesicle, bulla and all, we have covered in one of the videos in e-classes. You can refer that for more information. Yes. So option B is right answer, IgG. Okay. So we'll have, yes, epidermal cell. We'll have a brief summary of all that we have discussed so far, and then we'll conclude the session, right? So first we have seen, or we have gone through unicameral bone cyst. Unicameral bone cyst has many synonyms, right? So it is a false cyst as epithelial lining is absent. And then we have gone through Lobstein's disease or osteogenesis imperfecta, where we have porous bones which are more prone for fracture, right? So the quality of bone which is being formed is not good, right? So along with that, we have other clinical characteristic features like blue sclera, which are also found in other conditions as mentioned. So achondroplasia mainly because of FGFR3 gene coding for this receptor protein is mutated, because of which we have this achondroplasia, right? Defective endocartilage or endochondral ossification or defective formation of cartilage, right? Fibrous growth plate, etc. And then we have gone through Fessas bodies which are found in case of beta thalassemia because of excess accumulation of alpha chains in erythrocytes and their precursors, leading to their destruction eventually, and also defective hematopoiesis. And finally, we have gone through the antibodies which are implicated in the pathogenesis of bullous pemphigoid, and these are IgG autoantibodies directed against hemidesmosomal bullous pemphigoid antigens numbered 230 and 180, leading to destruction of these antigens in the basal membrane, recruiting the inflammatory cells, thereby leading to release of proteases which cause destruction of these proteins, that is the antigens BP230 and 180, leading to formation of blisters subepidermal, right? So this is in brief few important points which I wanted to highlight in this current video. So tomorrow we shall come up with a few more topics from microbiology. You can go through Google Group for the soft copy, you can download it, you can solve the questions before attending the live session, and once you start attending the live session with solved paper, the preparation will be even more effective, right? So if you have any further questions, you can drop them at proudtobedentist@gmail.com. And by the way, we started our Mission Full batch last week, and those are willing to join. For more details, you can contact us again to the same mail ID, or even you can even check our website ptbdacademy.com, right? Yes, definitely. I'll let you know if at all I have any information pertaining to counseling. I'll definitely post that in Google group as well as in our WhatsApp update group, right? Anushka, you can just drop a mail at proudtobedentist@gmail.com for more details regarding the test, right? Seshank, you have any questions, any doubts, do follow the protocol which we have mentioned and you can drop them to my mail, right? We don't have any separate session for paper discussion because we're providing explanatory answers, and for cumulative tests you'll be having paper discussion videos. So you have any further queries, you can drop them to my mail, but provided make sure that you're following the protocol while you're asking any doubt or query, right? Yes, Komal, drop a mail, I'll send you the link for Google Group. Okay? Yes, you're welcome. Yes, Chavi, Akshaya, Srish, Sunitha, Gargi, Harshit, Seshank, Ganga, Subhasish. You're most welcome, right? So see you again tomorrow by 8 p.m. Yes, Aishwarya, you're welcome. Anushka, you're most welcome. Okay, Ajay has some information for you all. He says, interestingly, both hypo and hyperthyroidism cause macroglossia. Okay. You're welcome, Devna. Yes, Preeti, right? See you again tomorrow by 8 p.m., right? Make sure that you go through the soft copy of the questions and come to live session after solving them so that you can enjoy the process of discussion. Fine? Yeah, love you all. Take care. Bye. Yes, Paricha, you're most welcome.